The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're having our special holiday edition. Welcome to the holidays with Tim Bahr and alloimmunization. Welcome back, Tim.
Thanks. I like this tradition, Paul. It's our triannual tradition.
Our triannual tradition. It's a wonderful.
That's a word.
It should be. So would you mind sharing your disclosures with us again?
I'm an investigator as part of a phase 3 drug trial for a drug called nipocalimab here at Intermountain Health. And so that is my disclosure. I receive research support, nothing beyond my salary, and I own no stock, but they definitely support our research program, Johnson & Johnson.
Excellent. We're going to be covering some material that we talked about a little bit last week, trying to put it into a context so that we can apply it. And you're teaching me, so we may have to do things more than once.
No worries.
So let's start off with the importance of maternal testing. At the end of the last episode, you talked about how important universal maternal testing is. Can you help me understand what's the difference between the three terms that we hear about: Coombs test, a DAT, and an IAT?
So Coombs was the person who invented, I guess, actually I don't know who Coombs is, but I assume the test that is the IAT and the DAT were named after somebody named Coombs. IAT and DAT stand for the indirect antiglobulin test, and DAT stands for the direct antiglobulin test. And if you have a chance, just review one of these images. We stared at medical school, and I probably memorized and maybe got right, if I was lucky, the right day. But an indirect antiglobulin test looks for anti-red blood cell antibodies that are floating around in the serum. And if you have an indirect antiglobulin test that is positive, in the context we're talking about today, that means you're alloimmunized. So why do we do that test? That test is a test that is most commonly used before you give blood to somebody. And the reason why is because if they're alloimmunized against KEL and they have anti-KEL antibodies floating around, we need to know that so that I don't give them KEL positive blood, because it would result in major morbidity and possibly death. So the indirect antiglobulin test is not a standard test in babies if I don't think they're going to need a transfusion. It is a test that we perform before performing a red blood cell transfusion to make sure that person doesn't have antibodies against the blood that I'm about to give them. The direct antiglobulin test, at least in my practice, is a common test we give to babies. So I guess let me back a step. Indirect antiglobulin test, not only is it a test I do before I transfuse somebody, it's a test that we perform in pregnancy. So before transfusion and in pregnancy, and that's because I need to know if this mother is alloimmunized, because similar physiology to transfusion, the antibodies that she may have against red blood cell antigens can cross the placenta and cause hemolytic disease of the fetus and newborn. So the easiest way to remember it is the indirect antiglobulin test, more commonly known as the antibody screen, and is a test for mothers, most commonly in our practice. The DA test is the test for babies. So what does a DAT, a direct antiglobulin test, tell me, or also known as a direct Coombs, is that it tells me that there is actually alloantibodies, presumably from the mother, that have attached to the baby's red blood cells. And I generally say that a positive DAT in the setting of an infant born to an alloimmunized mother is synonymous with hemolytic disease of the newborn, or hemolytic disease of the fetus and newborn. So IAT, or antibody screen, or indirect antiglobulin test, is a mom's test, generally speaking, and DAT is the baby test.
So if a mother has a positive IAT, how do I respond now when the baby's born?
Yeah. When the baby's born, if she has a positive IAT, we should be more vigilant. And what we should do is we should pull up the August 2022 bilirubin guidelines from the AAP, because they'll tell you exactly what to do. The guidelines that we hope to publish soon from our consensus group say that is not a baby that we wait to check bilirubin and other labs on until pre-discharge or 24 hours. If that baby is born to an alloimmunized mom at birth, preferably from the cord blood, at birth, they need a bilirubin test, a total serum bilirubin. Ideally, they need a CBC to see if they're anemic. And then we'll also do a DAT, a direct antiglobulin test, or direct Coombs, if you will, to see if the baby actually has the antigen and if those antibodies are attached to the red blood cell.
Very helpful. So at what point is the obstetrician going to determine what antibodies are present?
ACOG guidelines say at their first visit. And so I believe they actually say between 8 and 12 weeks, sorry, maybe 10 to 14 weeks is when the first, actually, I believe it's as early as 8 weeks, is when the first maternal visit in pregnancy is recommended. At that visit, we sometimes say the maternal serologies should be obtained. And that includes the antibody screen, which is to detect antibodies against red blood cell antigens that their fetus may or may not have.
Okay, so let's go on now. So the infant has been delivered. What maternal findings require immediate testing in a newborn?
What maternal findings require immediate testing in the newborn? Yes. So generally
Antibody presence or...
Yep. Any infant born to a mother who has antibodies, who is antibody screen positive, should have a screening for HDFN as soon as they're born. And that's why it's important for us to recognize this early. So our recommendation, and I believe the AAP's recommendation is the same, is that we should do a total serum bilirubin on that baby immediately, a CBC to screen for anemia, and then usually a DAT I would recommend, and I believe the AAP also recommends, to confirm the disease. The only exception to that is we now have the ability to test the antigen status of the baby, to test whether the fetus and baby have something like the D antigen. We're able to do that with cell-free fetal DNA in prenatal screening. So the one exception to that testing, when you are caring for a newborn or you're notified that a newborn is born to a mother who is alloimmunized, you perform those tests. The one exception may be if they've already screened the fetus and found that the fetus is antigen negative for the antibodies which the mother has. We still actually do recommend that you do a DAT to confirm that it's negative, to confirm that prenatal testing was correct and that the newborn does not have that antigen. But I think for all intents and purposes, Paul, I would say if I'm a pediatrician in the newborn nursery or in the NICU or wherever you may be, and I have a baby and the antibody screen was positive in the mom and it wasn't due to RHIG, to ROGAM, then we go ahead and screen that baby immediately per the AAP guidelines for hyperbilirubinemia, anemia, and also perform a DAT to confirm whether or not the baby has the disease.
Because as you taught me last week, we're doing those tests because we're looking for hemolysis that's already happening to the fetus before they're born.
Correct. Yep. As far as I understand, the process of hemolysis is not a whole lot different in the fetus than it is in the newborn. The great benefit of the placenta is that it can remove the bilirubin. Bilirubin can cross the placenta. So babies tend not to be born with these bilirubins of 20 and 25. But once the cord is cut, yep, that can develop really quickly in the setting of alloimmunization and HDFN.
Here's a practice question for you. Does every infant born to an O-positive mother need a blood type?
Good question. The most recent research, and I guess this is probably Bob Christensen, now 15 years old, 10 years old research, is that no. We have found that if the mother's antibody screen is negative and that mother is type O positive or type O, then we do not have to do a type and DAT on the baby. The reason why is because those infants in the setting of universal bilirubin screening are at no higher risk of poor outcomes than their peers. So I'd say about 10 or 15 years ago, we made the realization that practice of doing a type and DAT on every infant born to a type O mother is no longer necessary. And that, I would say, one caveat, that was under the 2004 guidelines from the AAP. We use higher thresholds, but generally speaking, yes, you do not need to type and do a direct Coombs on every baby born to a type O, only if the mom is antibody screen positive. The other reason why they do it is if she's Rh negative, that's for RhoGAM administration. If the DAT is negative in the infant, you don't have to administer RhoGAM to an Rh negative mother.
And based on what you taught me last week, with an ABO incompatibility, do I need to be more on guard about an indolent reaction?
Generally, no. So universal bilirubin screening that is now the standard of care recommended by the AAP in the United States is sufficient. So if there is ABO incompatibility, if you do have a type O mom that gives birth to a type AB or AB infant, and the mother is antibody screen negative, you do not need to have an elevated level of concern. Universal screening should be sufficient. The caveat there is that the AAP still considers a positive DAT to be a neurotoxicity risk factor. I agree with that, but the DAT is not a mandated test in all babies born to a type O mom, only those with an antibody screen that is positive.
Very helpful. The baby's been born now. We've gotten the immediate tests, and they may reflect ongoing hemolysis, and those tests may say you need to do something right now. What's the role of bilirubin trajectory, reticulocyte count, and a peripheral smear in making a decision?
Yeah, so let's make sure we got those right. You said
The trajectory of the bilirubin,
uh-huh.
the reticulocyte count, and a peripheral smear.
Yeah. The recommendations from the AAP is to check these babies more frequently. And there's a little bit of art to this based on where the baby's at. And so the trajectory can be very helpful, just like it is in any baby with hyperbilirubinemia. If I have a baby that's rising at a very high rate, obviously I need to watch that baby closer. The general rule of thumb that we use based on the slope of the original Butani curves was 0.2 milligrams per deciliter per hour.
Mm-hmm.
And we still find that to be helpful. In Billy Tool, which is a nonprofit company that implements the AAP guidelines on their website, or in Epic, I'm sorry not to use company names,
Sure.
in your electronic medical record, oftentimes they will calculate the rate of rise of that. And I think that's still a good rule of thumb. So yes, trajectory of the bilirubin can be very helpful to help you understand how severe the disease is.
How helpful is reticulocyte count?
It's helpful. So reticulocyte count, can be a marker of hemolysis. So in the new guidelines that I think we'll have a chance of talking about, that we hope to be published soon. Yeah, great. We do recommend a CBC and a reticulocyte count. A reticulocyte count that is elevated, that depending on how old the baby is, it is a marker of hemolysis and accelerated destruction. It means the bone marrow is cranking out red blood cells as fast as it can to keep those oxygen carriers coming. So an elevated reticulocyte count can be helpful in helping as a marker of hemolysis. The one other thing I would say it can do is, this is maybe a little bit more of a neonatologist question, but sometimes in these babies, I guess an elevated one suggests possibly ongoing hemolysis. The one other thing it can do is sometimes when I'm trying to decide how soon a baby with HDFN may need a transfusion, the ones that really get into trouble are the ones that are making no new red blood cells.
Oh, sure.
And they're anemic. So the retic count tells us how quickly the bone marrow is cranking out new red blood cells. And so if you have an anemic baby with a retic count that's less than 1%, that's a bad thing. If you have a baby that's not anemic and has a high retic count, that might mean they're hemolyzing. They're not in trouble yet, but you need to look to the future. And then the last one you asked about was, remind me,
A
Paul.
smear. A peripheral smear.
Yeah, I still find these to be helpful. I would say that the peripheral smear tends to be more helpful when I don't know the cause of hemolysis. In these cases, when you have an infant born to an alloimmunized mom with a positive DAT that's got severe hyperbilirubinemia, usually I know what the cause is, or at least I assume that the only cause is the HDFN. And in that case, maybe the smear is probably not as helpful.
Here's a softball question. When's the right time to involve neonatology or hematology in the conversation?
Yeah. So neonatology, I think we have more neonatologists in most states than we have hematologists, and we're always happy to help. So I'm never concerned. I would never be concerned or be upset about a question from an awesome provider that had a question about alloimmunization. So I would say the time to involve them is early. The hospitals that I work at, we actually have specific guidelines of when you're supposed to consult neonatology. And actually, we ask the general pediatricians to consult a neonatologist whenever they are caring for an infant born to an alloimmunized mother. And so I think you can consult them anytime you want and make sure that the care that you're providing is appropriate. Hematology, in our guidelines that hope to be published soon in one of our journals, recommend that a baby who is at risk of needing a transfusion in the future, generally babies that have severe disease, should be referred to hematology prior to discharge from their birth hospitalization.
When should an infant be transferred to a higher level of care?
Yeah, great question. Again, I think a consultation with a neonatologist can be very helpful. We recommend that any pregnancy that falls into a high-risk alloimmunization category be delivered at a hospital with a level 3 NICU. We consider an alloimmunized mother to be in a high-risk HDFN category when they have an antibody titer, and a titer is a way of measuring the amount of antibody in the circulation. If she has a titer greater than 16 of any antibody, or KEL greater than 4, and in Intermountain Health hospitals, it's actually KEL of any titer, we recommend that they be delivered to a hospital with a level 3 NICU. And when do they need to be transferred to higher level of care? In those high-risk situations, once I confirm that the DAT is positive, that the infant has the antigen, we actually automatically admit the baby to the NICU to make sure they get the intensive care that they need.
So what you're saying is that for a lot of these babies, the right time to be transferred is while they're still a fetus.
Yeah, that's
I mean,
right. It is. We need to prepare. Yep. And Paul, I think it's important to point out one thing about this disease that's a little tough. It is a spectrum of severity. And to give you a sense, the incidence in the state of Utah, according to my estimates, is about 3 per 1,000 births. So I say that's 3 times as common as trisomy 21 to have an infant born to an alloimmunized mom, roughly speaking, right? Now, in the Intermountain hospitals, we care for about 200 to 300 alloimmunized pregnancies per year. I would say 90% of those are low risk. And then 8% of those, of the remaining 10%, are high risk, and another 2% of them are extremely high risk and may require something like an intrauterine fetal transfusion as a fetus. So that's why I recommend the neonatology consultation, or following the guidelines that you have at your hospital if they have them in place, because our goal is not to overtreat, but we certainly don't want to miss these. If I may use an example, if I have an infant born to a mother who is HIV positive, I automatically consult infectious diseases. Sure. I don't do it very often, right?
Right.
And
right.
so I think likewise, if you have any question, just go ahead and consult neonatology. Call your friendly neighborhood neonatologist and ask them, hey, what do we need to do? And they should be able to give you a bit of guidance.
And so to summarize, what I understand there is that there are some babies who need transfer to a center where the fetus can receive intervention. There are some who have a high enough index of suspicion that they should be at a place where there's a level of care that if there's a high suspicion, there's going to be a problem, that intervention can happen immediately. And that for the other ones, for me, as a practicing pediatrician, that being aware of the potential for harm and being aware that a consultation is the right way to make sure that we deliver the right care is absolutely vital.
Absolutely. Yep. Best case scenario is we say, hey, we confirm this is a low risk infant, keep him in the well baby nursery, Billy's low, or the baby's DAT negative, and just continue on with life.
Perfect. So let me just summarize. This is going to sound a little simplistic, but thorough evaluation, including a good maternal history. If we find that the strategic lab work has not been done, we should make sure that's done as soon as possible around the time of delivery. And then that we're aware of what we should be looking for, and consultation is not a sign of weakness.
Absolutely. Yeah. Never a sign of weakness.
All right. I feel a little smarter, Tim. Next week, we're going to talk about the management of hemolytic disease. We're going to talk about the new guidelines. I'm sure there are a lot of questions. Please send your questions to questions@vcurb.com, and we'll deal with those in a couple of weeks. In the meantime, thanks so much for your time, Tim.
Great to be here. Thanks, Paul.
All right. Talk to you next week.
Talk to you next week.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.